Good afternoon. My name is Ninez Ponce, and I'm an Associate Director here at the UCLA Center for Health Policy Research. Welcome to today's seminar. The title is California Health Interview Survey 2018 Data Release. As the nation's largest state-level health survey, the California Health Interview Survey, or CHIS as we fondly call it, has provided vital data on health insurance, health status, and access to care for California residents, and is used by a broad array of organizations and stakeholders to promote health and well-being of Californians. CHIS began in 2001, and since then it has been recognized for its value as a high-quality data source on population health and its contributions to survey science. CHIS is nimble and captures the latest challenges in California, such as, has health insurance coverage in California gone up or down? Are consumers wooed by flavored e-cigarettes? Is the need for mental health care services growing? So, in today's seminar, Dr. Ninez Ponce, Director of the Center, and Todd Hughes, Director of the California Health Interview Survey, will discuss a wide range of findings from the just released 2018 CHIS. New and expanded topics include detailed questions on well-being, marijuana and e-cigarette use among adults and teens, as well as continuing questions on many topics such as health status, food consumption, dental visits, and access to care, to name just a few. As always, today's slides are available on our website, or they can be requested from our communications department at the email address that you see here on your screen. We have had this is our second seminar in October, and we have an upcoming holiday. It's not Halloween, but Thanksgiving. We will skip our November seminar. In December, Imelda Padilla-Frausto will present a seminar on mental health needs in California. Please check the seminar page at a later date for details. Also, please note that we have 3 members of the CHIS team, Andrew Yunke, Royce Park, and Yuqing Yang, monitoring and responding to online questions. So bring it on. We will serve the last 15 minutes of the seminar for Q&A for in-person and online participants. So now let's begin. Oops. Let's begin today's discussion with Dr. Ninez Ponce and Todd Hughes.
Thank you so much, Dr. Parad, and welcome everybody here. It's so exciting to release data. Note that last year and the year before, we released on Halloween, and so we're getting a week earlier. Maybe we'll get earlier even more next year, but I'm so excited today. So today's presentation is going to be highlights and tidbits, but we're going to do a handoff between Todd Hughes, the CHIS director, and myself. So I would be, I'm going to hand this off to Todd Hughes first.
Thank you, Ninez, and hello, everyone. I'm Todd Hughes. I'm the director of the California Health Interview Survey, or CHIS, and I'm very pleased to share with you all the public release of some rich information that we collected in the 2018 iteration of the California Health Interview Survey. If you're less familiar with the CHIS survey, first I'd like to provide you some general background information. So the CHIS is the nation's largest ongoing state health survey. It's a comprehensive source of health information on Californians that covers an extensive, diverse, and timely range of health topics. From key issues on health status, health conditions, and health behaviors, to mental health and oral health, to access to health care, to employment and other social determinants of health, and certainly extensive information regarding health insurance coverage for Californians. The CHIS has something for almost everyone and is continuously evolving to reflect current information needs. This truly is an invaluable assessment tool for population health data, meeting both state and local needs, whether it be for policy analysis and advocacy, service and program planning, or many other custom research needs. Many organizations have demonstrated the value of CHIS through their financial support of the survey and their collaboration with us in conducting the survey each year. This includes federal and state health agencies, California and national foundations, and more. And I'd like to thank these organizations for their ongoing support of the survey. The design of the CHIS provides estimates for the state of California as a whole, as well as many other population groups. This includes smaller levels of geography, including most counties, as well as cities with health departments. We also produce estimates for all of California's major racial ethnic groups, as well as some of the smaller ethnic groups. Additionally, it has been a key mission of the CHIS to share the information from the survey broadly to a diverse set of audiences and data users. Next, I'd like to describe for you a little bit about how we conduct the CHIS. The 2018 survey was conducted by telephone, and CHIS phone interviewers worked to collect information about 3 different age groups using modified questionnaires for each. First, we interviewed 1 adult, age 18 and over, in the household. If that adult is the parent of children living in the household, we also ask that same adult questions about 1 child, age 11 years old or younger. Additionally, if there is a teenager in the household, we ask the adult their permission to interview directly 1 teen, age 12 to 17. To better reflect the diversity of California's population, we also provide language support in conducting interviews in many languages, including English, Spanish, Chinese in both Cantonese and Mandarin dialects, Korean, Vietnamese, and Tagalog. And if you're interested in seeing the translated versions of these questionnaires, they are available on our website. The table on this slide provides information on how many interviews we conducted by age group and by ethnicity. In 2018, CHIS completed interviews for over 21,000 adults, over 400 adolescents, and almost 1,600 children. Because it reflects California's diversity, CHIS is relied upon for its wealth of data on many racial, ethnic, and gender minority groups, and therefore counts of interviews in 2018 by each of these racial ethnic groups are displayed here on the slide. The CHIS relies upon different sampling strategies to ensure that we can effectively represent these varied groups to the extent possible. As I mentioned earlier, the CHIS evolves each cycle to better reflect current information needs. The next few slides provide a glimpse of what's new in the 2018 survey. Several new topics were added to the adult questionnaire in 2018, including questions related to non-cigarette tobacco use, additional questions on the use of flavored tobacco and e-cigarette products, questions on secondhand smoke exposure and rules about smoking and vaping, and a set of questions measuring perceptions of current and future well-being. One new topic was added back to the teen questionnaire in 2018, and that is the condition of teeth and missing school due to dental problems. Data for these new and reinstated topics are available through our public use files, as well as in our Ask CHIS data dissemination platform. For more information about changes in the administration of the 2017 and 2018 iterations of the CHIS, we encourage you to explore the documentation available on our website, such as the What's New and Notable document shown here. Other very detailed reports describing our methodology can also be found on this site. Now, I know you're as anxious to see some of the survey results as we are to share them. So let me turn the podium back to Dr. Ninez Ponce for a discussion of some interesting findings from the 2018 CHIS. Ninez.
Thank you, Todd. Okay. Here's a snapshot of the uninsured rate for California. It's at 8.1%. for Californians who are age 0 to 64. And this is about a drop in the uninsured rates from 2013 from 15.5% to 8.1%. So almost cut by half. What CHIS does though is not just provide one-year snapshots, but we can also show what the trend is across all the years. We've been collecting data since 2001, But some key years have been pre-ACA, which fully launched in 2014, and then post-ACA. So in this particular slide, this is the uninsured rate. And what we see is that the uninsured rate continues to be a low, around the 8% range. And it counters national trends, where the national trends are that the uninsured rates have actually gone up between 17 and 18. A lot of what drives this, drop in uninsured rate is through the expansion of the Medi-Cal program, California's Medicaid program. And as we see here again, that there's a dramatic rise in coverage from 2013 to 2016, and then a bit of a tapering off and a stability from 17 to 18. So just to be mindful, this is the uninsured rate, and now I'm showing you different sources of coverage, with Medi-Cal being a big source of coverage for Californians. Employer-sponsored insurance, that is insurance that that individuals and their families get from their jobs, has also been very steady. It's a great source of coverage for Californians as well as the United States. And we see that it dropped a bit between 14 and 16, but then an uptick in 17, but then fairly stable between 17 and 18. So this could be because of California's economy, getting stronger in the recent years. The Affordable Care Act also introduced Covered California, which is the state health insurance exchange. And this yellow line down here is the individual market, or what we're labeling as private purchase. This is the market where consumers can purchase insurance directly, so it's not through their employer. And so Covered California is a component of this market, and we see that fairly steady from 2014, actually a big jump from 13 to 14 when Covered California came into the scene. And then just, again, some stability through the years, and actually some stability in 17, 18. So the point estimates may jump around, but there's some asterisks and some crosses that show significant differences. And if you want to learn more about this, and so let's put the whole picture. Okay, so here the last piece is the other public. This other public is a tiny component of coverage for Californians, but it includes other public programs such as Champus, VA, and also if some Californians under age 65 may have Medicare. So in this particular case, this is through a analysis from a policy brief. I'm just going to show it here. So please download it. So the charts are here. I'm actually going to show two more charts. But I actually replicated this morning when Ask just came live. What time did it come live? Actually, late last night. Late last night. Okay, so my morning came live this morning, and I replicated this chart. So you can do this on Ask Chis. Just be sure that you limit the age to 0 to 64 to replicate this. So what does it mean, this uninsured rates? It's stable, but how does it look across different segments of California's population? So for race ethnicity, it's fairly steady. If we look at the black bar here is the 2013 anchor point. Again, this is the pre-ACA anchor point. And we see it's much higher for all the different groups. And then a gradient, a decline in uninsured rate, pretty much across all the different groups. So it's steady, the declines are steady, but we note that uninsured rates are still highest for the Latino population in California. By income. So income here is measured as a percentage of the federal poverty guidelines. And in this case, we also see that across all income groups that there's a decline since 2013 in the uninsured rate. But an income gap obviously still exists because this group here is the highest, are Californians that earn incomes 400% FPG and higher, and the uninsured rates are lower there. So this income gap still persists, but it is lowering if we compare 2013 to 2018. Let's turn now to mental health and why health insurance is so important. So for mental health, if you joined us last year, we saw this dramatic increase between 2016 and 2017 on several measures on mental health. One of them being psychological distress in the last year, and so this is the asterisk here is a significant increase from the previous year. So in 17 there was a significant jump by 2 percentage points of all adults 18 and older who reported that they likely had some psychological distress in the last year. And we also saw that those that needed help for emotional and mental health in the last year also increased significantly between 16 and 17. Between 17 and 18, it's for the psychological distress, it's remained fairly stable compared to 17, but still much higher than 2016. And then a whopping increase in the needed help for emotional, mental, or alcohol drug problem in the last year from 18.5% to 21.2%. This asterisk means that it is significantly different than the 17 data. So this is increasing, definitely much bigger than the 16.4% of rate in 2016. Not seeing anything significant and saw any healthcare provider regarding mental health problems and challenges between 16, 17, and 18. But we do have a question on suicide ideation and CHIS. And last year, we saw an increase between 16 and 17 that was significant, from about 9% to almost 12%. And unfortunately, in 2018, we're seeing that this trend is continuing among all adults, and that the 13% is significantly different from the previous year of 11.6%. CHIS is a population survey, so we survey across all age groups. And so in CHIS, you can also subset the adult population. So you don't just look at all the 18 and older. As we saw in the insurance, we looked at adults up to age 65. And here we subset to young adults, ages 18 to 24. And in this population, we're seeing an amplification of the trends that we're seeing for all adults, much higher rates of psychological distress, and needed help for emotional and mental health problems, and ever seriously thought of committing suicide. And these rates have increased from 16 to 17 significantly. I think all except for the ever seriously thought of committing suicide. And for 18, there is no significant difference across these measures between 18 and 17, but they still are really important measures to consider for California's young adult population. Okay, let's turn to pot. So this is what's new in CHIS, and I have to have a cheat sheet to talk about this population. So what this chart shows is that we ask a question in CHIS of have you ever used pot? So if you use pot, if you're 60 and you use pot 40 years ago, that would be a yes. And then for those adults that say that I've used, and actually I think the question is more even tried, that then there's a question of have you used it within the past 30 days, within the past month? So for adults who have ever used pot, we find that more than half of California's population have ever used pot. But among that population, a third are actually currently using it. So this is a way to interpret this. Now, if you want the entire population, you would multiply 33 times 53, and that would be about 17.7%. And so think about that denominator of the whole population as I take you through some other, I got excited about this. So again, this is now the population estimate. So it's about 17.7% overall for all adults in California. So what we did here, because also another feature of CHIS is that we have county and county group estimates. So you can get estimates at the sub-state level. And in this case, we looked at the top 10 counties where adults age 18 plus have used marijuana in the past 30 days and the bottom 10 counties. And so we present that here for you. If your county is not here, you're somewhere in the middle, you can also find that out in CHIS. Also in CHIS is the preferred delivery modes. How are Californians currently use pot? And for young adults, again, we're focusing on young adults and the next slide will be on teens. In this case, for young adults, we're finding that great majority are using pot through a joint, a bong, or a pipe. And then the next most popular way of using pot is through vaping, 46.4%. Now on teens, and the teen sample in CHIS is from 12 to 17. So among teens, also a joint bong pipe is the top choice, but it's 55%. Remember, the young adults was over 80%. And but vaping is 38.9%. But what's also, actually, it's not the top. Sorry, the top is actually blunting at 56.3%. So about the same as the joint bong pipe. And a blunt is a rolled cigarette, either with tobacco leaves or with cigar leaves. And there's also some questions in CHIS on how California adults who are tobacco chewers or who are vapors, whether they prefer flavored products, because as we know, some of these products are marketed, based on very attractive flavors, very palatable flavors, and we're seeing it's about it's half and half in terms of the chewing tobacco with the preference for flavored, but definitely for e-cigs that there is a preponderance of favoring the flavored products, 7 and 10. And I think that may be my last pot and e-cig slide. Let's turn now to quality of life. How are Californians doing? So new in CHIS is this question on current and expected quality of life. It's based on a measure that's been used both nationally and globally. And it's pretty much a measure of you're picturing yourself, picture a ladder, and where are you on this ladder, where 0 would be, so 0 would be the lowest, and then 10 would be the highest. And we're it's by age, the proportion, the adults in our sample, and adults in the population who are older actually are quite satisfied. I mean, they seem to have higher satisfaction rates than the younger age population in CHIS. But there's also a question of current, but what about future? Where do you see yourself? What the satisfaction would be in the future, and so then we see this reversal, which isn't unusual, that among the 18 to 24-year-olds and the 25 to 65-year-olds, that there's definitely an aspirational, my life will be better in the future, but among the age 66 plus, that it's about the same, but it's not a higher rate than the current, and I think that that's expected. If you look at income, then there is an income gradient. So it looks like the higher income you have, then the more you're going to rate a higher current life satisfaction. But everybody also is slightly higher. Like this here is the change from current to perceived. So this is all above 0. So everybody is again thinking that life is going to be better regardless of their income in the future. But again, the expectation that there's this gradient here by income. And by race ethnicity, so here we're looking at the major racial ethnic groups, and we do see some variation, but not much, and they're statistically about the same in current life satisfaction. We do see some lows here, and this group here is the Asian population. It's lower than the others, and it doesn't actually budge that much, as you see here, between current and perceived. We do see among whites, it's also kind of the same. Whites though here are the highest, and it doesn't budge that much in terms of if you compare current to perceived. So sort of at the extremes, Asians rated current life satisfaction lowest, whites rated it highest, and both rated it that the expectation isn't going to be as high. I note that this particular slide, as well as the other slide on income and poverty as a percent of poverty level, are age adjusted, because there may be compositional changes, for example, within the racial ethnic groups. I think I'm up. I'm no longer up, so I'm going to bring you Todd Hughes.
Thank you, Ninez. So I'm sure you all found these results very interesting, and I'm happy to inform you that there is a wealth of other information available from the 2018 CHIS that is ready for you to explore, which we could not highlight all in today's seminar. And next, I'd like to describe some of the tools with which you may explore those data. So it is the mission of the CHIS to share our survey data broadly, but ultimately our highest priority is to respect the confidentiality of those respondents who provide us their information. So with those protections in place, we then focus on democratizing access to the data, to put data into the hands of as many people who can use it as possible. And to do that effectively, we must provide different sets of tools that reflect the needs of a large and diverse audience across divides of technology, skills, and resources. So this slide highlights some of those varied tools. The two rows at the top in purple really reflect those who are the most savvy data users. For these users, we provide public use files as free downloads. For researchers who need to run analyses on the most detailed raw data, we provide internal statistical expertise and programming support in our Data Access Center, delivering then statistical output externally to the researcher while limiting access to the confidential data internally. The three tools in orange on this slide are designed to make the data accessible to the broadest set of users. These online tools enable anyone to explore data tables and maps presenting the rich CHIS data. And then finally, the green bar on the left, our health data program, provides online and in-person training to build capacity for the public to access and analyze CHIS data. Two of our most popular and powerful tools for presenting CHIS data are the Ask CHIS system and its partner Ask CHIS Neighborhood Edition. Ask CHIS provides powerful data tabulation tools to present tables and crosstabs with direct estimates for hundreds of CHIS indicators each year, primarily at the state and county level. This is the best tool to explore today's data release, the 2018 CHIS data. Ask CHIS Neighborhood Edition allows for visualizing modeled estimates for a subset of the CHIS indicators, but at much lower levels of geography, including assembly, senate, and congressional districts, as well as cities and zip codes. Neighborhood Edition was recently updated to include the 2016 CHIS data, and coming just in time for the holidays, we're very excited to be adding census tract level estimates to Neighborhood Edition. 2018 CHIS data are not yet available in Ask CHIS Neighborhood Edition, but will be later next year. This next slide shows a screenshot of how you can explore the CHIS data using Ask CHIS Neighborhood Edition. A very powerful map interface presents CHIS results for your selected geographic level. In this case, we're looking at zip code level data, and our map presents zip codes around Los Angeles. The system allows you to create custom groupings of zip codes as a very powerful tool to see results for your own custom areas of interest. So in this case, I've combined two zip codes here near UCLA, and the system presents the data for that area. You can see it presents data in both the color grading on the map, as well as the table at the top of the screen, as well as ranking this geographic area on a histogram at the bottom of the screen. Basic demographic and economic information for this custom geography I set is also presented on the left side of the map. And then at the far left side, you can see a list of all of the different CHIS indicators available for possible viewing, as well as some environmental factors and socio-demographic measures that are also available in the system. So if your interest has been piqued by this brief look at what Neighborhood Edition has to offer, let me point you out to some ways that you can learn more about how to use the system in detail. And I'm very pleased to say that we have a brief, free set of video tutorials available online at the site presented on this screen. And they can teach you both how to use the Ask CHIS system as well as the Ask CHIS Neighborhood Edition systems. These tutorials cover how to do basic queries, how to display data visually, how to export your data in different formats, as well as providing training on confidence intervals, pooling, statistical stability, and much more. And if you are a power user of CHIS data, or you just aspire to be, the 2018 CHIS public use files are also available now for free download on our site in a number of formats. These provide record level data for you to use in conducting your own analyses, and it's got somewhat reduced detailed information and removal of some sensitive questions in order to protect the confidentiality of our respondents. I would also like to share with you that in January of 2020, an expanded 2-year public use file covering the 2017 and 2018 CHIS data will be released. This expanded file is even more useful for many researchers because it has less aggregation of response data, such as more detailed race categories. This more detailed file is also free, but does require the user to complete a brief 1-page application explaining the use of any planned analysis and the requester's contact information. So stay tuned for more information about the release of that file in January. So in conclusion, we'd like to invite you to visit the CHIS homepage, www.chis.ucla.edu, for more information. I'd also like to express our special thanks to our data collection partner, SSRS, our content partner, PHI, the members of our advisory board and committees, and the rest of the UCLA CHPR CHIS team who are listed here on the screen and who I'm happy to say are seated here in the room to my left. Many thanks to each of them and to all of you for your attendance today. Thank you.
So we went through those in record time, Todd.
We did well.
So questions. Before we take some questions, I also wanted to thank the center's communication staff. Eliza is here, and the center's IT staff for making this Zoom meeting happen, and also the admin staff who make sure that how many are about 40 members here that are well fed, and that they don't trip over chairs here. But so thank you so much, Hala, for organizing this event.
Okay, it is now our opportunity to entertain any questions. So I believe we have someone with a microphone here in the room who can run around. If you have a question, we'll start here in the room if you'd like to raise your hand if you have any questions.
Hi, very nice presentation, thank you. I was wondering if you know how the California estimate for ever using pot compares to either any national estimates and or how it compares to other states that have also legalized marijuana use.
That was Sue Babby from the center. I don't have that because it's again, we wanted to compare for states like Colorado that have legalized, but we can try to get that and post it. We did look at e-cigarette use among teens in terms of a national trend. And a lot of the surveys are school-based versus population-based, but the proportions we were getting were similar. get my.
Very interesting findings. Thank you for presenting those. I have a question about the increases in the psychological distress and the need for services, and was just wondering, did you look at any other age groups and find any other differences, or did you look at any other sort of demographic excuse me, characteristics and see any differences? Just trying to understand if there's like some sort of explanation for why we might be seeing these increases.
Thank you. That was Imelda, who will be doing the webinar in December on mental health. So we're actually looking forward to some of the deep dive that you'll make. I mean, we just focused again on the young adult population was very important for us to focus on, and then sometimes we also highlighted populations where we were seeing significant differences, and definitely it was lighting up in the young adult population. But we will, for those who are interested, again, CHIS data is available, but again, another plug for the December webinar where Imelda will be presenting.
And just one additional comment. So you can certainly, anyone listening and those in the room can go from here to their desks into the Ask CHIS system and be able to query on these same indicators and customize the age ranges displayed to get answers to questions like that and any other creative questions that were piqued your interest as we gave our presentation.
I do think I did highlight this, that it's promising that there's that the young adults are getting mental health care, counseling. So there was an increase, both, but this is among those who need. So there was an increase. So I think that destigmatization is really important to ensure that that young adults will get the help that they need.
I think, did we have one more question here in the room for now? Okay.
Hi, also very, very nice presentation and two very timely topics, vaping and the mental health. I'm curious, so were these mental health questions also asked of teens?
We're looking at our team.
Our questionnaire coordinator.
Questionnaire coordinators. That was actually.
Yes, the mental health questions, the severe psychological distress is asked on the teen questionnaires. Are all four of these indicators on the teen questionnaire? We do ask about suicide ideation. I think I have a slightly different set of questions about obtaining services.
So we have it here. Dr. Steve Wallace, the Associate Director, shared with us. We have this is available by download, but this is the 2018 questionnaire topics. And there's check marks on whether it's in the adult, teen, or child. And for mental health status, it is in the teen. And the perceived need and access and utilization of mental health services also in the teen, and suicide ideation and attempts also in the teen. What's not, the well-being scale, kind of the whole spectrum of well-being as well, is not in the teen, or any kind of we also have some questions that are very relevant for the older adult population, the loneliness scale and the functional impairment scale. So that was not available for the teens.
We'll take one more here in the room and then we'll check for online. Go ahead.
Very, very exciting that we have data of what's of interest now. I was particularly interested in all of the marijuana and vaping data that you have. With the increase of the use of marijuana and vaping, along with still some stable tobacco use. Are you looking at secondhand smoke exposure at all? If not this year, will you be doing it in the future?
As well as rules around vaping in the home are both included in the 2018 CHIS data set. We did not highlight those results in today's webinar, but they are available in Ask CHIS.
Yeah, I think that that's very important, because the rules are, could be one way of mitigating some of the behavior on uptake of vaping and marijuana. And it's the first time we've used it, I believe. I double checked with the team. We haven't had those rules. Does a household have rules? And so again, I invite you to take a look at that.
All right, we'll pause for a moment. Do we have any online questions we need to address, or have our online monitors been handling all of those? Well, thank you to our moderators.
Or our participants are actually on Ask Chis now, probably doing.
Yeah, that's right.
Answering their own questions.
Okay. Yes, another question here in the room.
So actually, this slide that you landed on reminded me of another question I had about the jump in the e-cigarette use among young adults between 17 and 18, because prior to that it was, pretty stable. Do you have any insight into what might be going on there? I know it's a tough question.
Yeah, and again, this is related to ages 18 to 25. So these are young adults, 18 to 25. And it is a large jump, 17 to 18. I think what's going to be especially interesting is next year as we look at the 19 results in light of all of the, recent news and concerns about various lung disease issues being sparked by e-cigarette use. Does that have a compensating impact on this? Do we see a reduction in 19? I think there is other data that shows that, as producers like Blue and Juul, really have picked up market share and have expanded their distribution, that their sales have skyrocketed similar to the ways that we're seeing increases. And so I think proportionally the increase in 18 does reflect some of those other data that show that market increase is rising. Yeah.
So can you go to the health insurance slide? Shows all the different insurance levels. There you go, that one, that beautiful slide. So
That I recreated at 6 a.m.
right. So what's interesting, both in terms of the distribution, can you talk a little bit more about information that's in CHIS and Ask CHIS on sort of the quality of that insurance or the use of the insurance? Because having insurance in and of itself, we're seeing more and more people having problems even with insurance, either being able to pay for their coverage or being able to access medical care or get a specialist. So there's lots of, having insurance is kind of the first step of a chain of events. So can you talk a little bit more about what's in CHIS around sort of the broader access questions?
Thank you. Thanks for your question. So CHIS has a set of questions that get at access barriers or getting the state of, do you have trouble finding a specialist? Do you have trouble getting an appointment? Do you, I think that there's are there delays in foregone care? So we do have those questions. We didn't highlight them here, but as Dr. Wallace said, coverage is the first step. I mean, we're still not at universal coverage, but still we've made a dent in cutting the uninsured rate. But then then what happens with coverage? Is that coverage, is it effective coverage? Is it coverage that gets you access to the right providers and the kind of care that you need? The other point I wanted to make is that, when CHIS first came out, this was Rick's, health insurance was Rick's area of passion and expertise. And the California Health Interview Survey, Rick Brown, for those of you who, I doubt if you don't know who Rick is, but, and it was sort of called the California Health Insurance Survey because we had so many questions on insurance. So this slide here is on current coverage. What do you have now? There's actually questions on chronic uninsured rates. Have you been uninsured for all of the past 12 months? It also looks at just sort of going back and forth, from public and private insurance. And it gets at this, again, it gets at the state of stability in terms of coverage for Californians. And then with that, we have the access questions. Any other questions that we?
Well, you know, one of the real benefits of having a population-based survey to measure this is you not only get to find out about their coverage, you get to ask reasons why. You know, why were you without insurance? Why did you forego receiving care, whether or not you had insurance? So, you know, that's one of the real values of CHIS as well. Okay, looks like we've finished questions. Anything else online we should discuss before we conclude?
You're answering them all. Oh, you're being too efficient.
I love this.
The team has answered the online questions. But for those of us here, are there any answered questions that might be of importance for folks here?
Maybe we can get a microphone over to
Hi, this is Eliza with the center, relaying a question actually from one of the online participants who just wants to ask which questions, if any, have been dropped from the survey from the previous year.
And that was answered?
No.
So let me, sorry, go back to the link to the What's New document. So for information about questions that were added and dropped, most of those changes occur as we transition between 2-year data collection cycles. So that would be primarily the transition from 2016 to 2017. There were a lot of changes that occurred then. There were relatively few changes that occurred between 17 and 18. And those were the few that we had described on the earlier slide as well. So I don't believe there were any real loss of questions of note between 17 and 18.
Okay, just a quick add-on for the insurance questions is, as a population-based survey, we can detect those who don't go to a doctor, so those who had problems, don't have a usual source of care. So we get at the uninsured rate, which you won't, obviously, you're not going to get that in claims databases. But we also can model, because we have all of these sociodemographic, family composition, immigration status questions, we can model eligibility for public programs. So we can look at the uninsured who are eligible. So again, this is an opportunity then to outreach and to get at these populations that may be left behind. They're wholly eligible for Medicaid or for Covered California, for example, but they remain uninsured. And so again, it's an opportunity to identify who they are and what programs need to be developed to make sure that they get coverage.
I think I'd like to ask you to elaborate a little bit on the wealth of information that's available. And I think you do have a list of many, many studies that have been using CHIS data, and it's really instructive to be able to see what can be done with the survey. If you'd like to elaborate on that a little bit.
Sure. So, so each year we try to update at our website, the www.chis.ucla.com. Edu. Thank you.
Edu.
You type in the first part, you're going to get there. But
you came from the census.
I know, yeah, not .gov.
Okay.
It's .edu. So on that website, we do publish each year a document that shows the impact of the CHIS data that are released. And it includes all of the citations that we were able to identify in media, as well as academic articles and publications. It also describes ways in which CHIS data was used for legislative needs and advocacy efforts and other program implementation, to the extent that we're able to identify that information. So we try to update that document each year. Also, this year we conducted a broad survey of all of the data users we could identify through email blasts, trying to understand how they're using health data generally, as well as CHIS data specifically. And we have some interesting findings from that that we'll also be sharing online as well.
Yeah, I think the dissemination, let's go to that slide piece. What researchers may not know is that we geocode CHIS. And so the geocode then means you can link data of your choice. So for example, if you're an environmental health scientist, you may have some air pollution data, for example, to link to a CHIS respondent. And it would have to be done at our data access center. It's a restricted file, but it offers opportunities to increase the value of the CHIS data so that it's not just the CHIS data alone, but how we can get insights on the places where people live, both from the contextual, the percent poverty in that neighborhood, for example, but also some environmental health pieces. So I think that that's really important. And there's some novel projects where there's some researchers that are looking into hotspotting using Google Maps in certain areas of extreme heat, for example. There are linkages to, say, the network of community health centers. There are, other, I think Andrew's here, but he's the portal to getting that, getting your research approved. But I think I'm the last one to say yes, and so I've just marveled at all the ways that the CHIS data can be used to inform health policy, and in some cases, because as with Dr. Perot's presentation earlier this month on whole person care and the importance of social determinants, there's some researchers that are looking at non-medical care domains, but using the CHIS data because of its rich socio-demographic and geographical characteristics it's helping them and their insights on informing how you get rid of structural inequities in the social space.
We have an online question that is asking, did you have a harder time getting people to answer their phones and take the survey than in the past?
May I?
You may.
So I think the trend that we have been experiencing on the CHIS is the same trend that we've seen in many household surveys, and that is that the efficacy of using telephone to conduct an interview, a survey interview with households, is becoming more and more difficult. The culture around how we all interact with our phones has evolved. The technology available to block calls, to know exactly who's calling on your caller ID. None of us behave the same way with a phone call as we did 10 years, 20 years ago, when that landline rang in the hallway and you ran to get it immediately because you were so excited. But we don't act that way anymore. And so the CHIS had done 2 field experiments in 2018 in parallel with our CHIS production data collection to better explore some alternative methodologies that don't rely as heavily on the use of telephone. That would in fact select addresses and mail invitations to those addresses and invite them to go online to complete the survey. And then after a few invitations by mail, if they had not responded through web, we would then try to contact them by telephone if we had a phone number matched to their address. So we're excited to say that that research was very productive and provided key information for us to make design decisions. And we have implemented that methodology for the 2019 CHIS. So next year, as we have a similar seminar to share the results of 2019, California Health Interview Survey, it will be with an entirely updated and innovative methodology. All right, I think we're finished.
No, we still have 5 minutes. We still have 5 minutes. So I always think another addendum of how CHIS is used by policymakers is that CHIS is also the population data that is the population backbone for another Center for Health Policy product, CalSim, the California Simulation of Insurance Markets. And so CHIS is used in the CalSIM models, and it's a model that looks to the future and informs the use of health insurance, particularly covered California, and other questions that need to be answered by covered California and other state policymakers. CHIS is also used in another product that helps legislators. It's called the California California Health Policy Research Program. Benefits Program, thank you, CHBRP. I used to be part of CHBRP, and apologies, Garen Corbett, if you're watching. California Health Benefits Review Program, and CHBRP uses CHIS as the population model to model California's population with different health insurance products that are regulated by DMHCS or Department of Insurance. And Dr. Parad is our vice chair for that whole program for all UC. And so it's, again, CHIS is used for evaluation also as well, because it's continuous every year. Some researchers have used it where they don't have a control group for whatever reasons, because maybe funding, maybe ethical reasons. And so CHIS has been used as a population-based control group looking at evaluation studies across the years. And then we have the future predictions, which is with CalSIM and with CHBRP. Okay, I think that's it. All right, so that's a wrap. We'll see you. Please use use our data, use CHIS, and thank you again to the team here. They're all over here for making this happen. Thank you.